Slowly. So the objectives of this talk, because the prostate cancer is a huge talk, and we have two main categories. One we call it the hormone-sensitive prostate cancer, metastatic, and the other one is the castration-resistant prostate cancer. So we'll just focus today into the hormone-sensitive and see what are the latest, especially from 2017 on Abiraterone Acetate and prednisolone. Prostate cancer is the second most common worldwide, and in our country, around 306 cases of prostate cancer, which accounts for about 5.8%. It ranks the sixth among male, and the median age 72 years old. This is how they present. Initially, most of them metastatic or localized and advanced. So this is just to show the rapid evolution into the treatment of prostate cancer as in other cancers, and expected, especially over the last 10 years. In 1940, maybe to 2004, the treatment was androgen deprivation therapy. So for prostate cancer, it's a testosterone-driven cancer. So you have to block that testosterone just to regress the tumor. And that could be done chemically by giving the anti-androgen treatment as the Lupron, or the anti-androgen as the flutamide, or surgical with the bilateral or orchiectomy. Till 2004, when the docetaxel was tested in 2 landmark studies and approved as a treatment for the patients who had a castration-resistant prostate cancer at that time. And then since 2010, over the last 7 years, you can see how many medications approved. Cabazitaxel is a chemotherapy, more or less as the docetaxel, with different toxicity. Spoliosil is one of the vaccine-like treatment. Abiraterone is the inhibitor for the 17-hydroxylase enzyme, which is enzyme important into the synthesis of the androgen. Enzalutamide is one of the potent anti-androgen receptors inhibitors. So those medications all were tested into the castration-resistant and approved. And now into the castration resistance, we have two main categories. One we call it a docetaxel naive or post-docetaxel. So that's another talk. But for the hormone sensitive, the androgen deprivation therapy remains the treatment without any of those medications until about 2 years ago, when investigators tried to bring all those medications early to the hormone sensitive stage. So it started with the chemohormonal, where the docetaxel brought to the first line through 3 landmark studies. They call it the CHAARTED trial, GTUG 15, and STAMPEDE trial. So the CHAARTED trial took all those patients with the hormone sensitive metastatic at the time of the presentation, and randomized to androgen deprivation therapy plus 6 cycles of docetaxel, given as the standard dose, 75 milligram per square meter, and the control arm was just only androgen deprivation therapy. It showed during that time the concept of something they call it a high volume disease, which was defined as a bony lesions more than 3, one of them outside the skeleton of the vertebra, and also visceral metastasis, compared to the low volume disease, which is another presentation. This is the update into the CHAARTED trial. What it showed that the androgen deprivation therapy plus docetaxel with a remarkable response also in the overall survival, which was the primary endpoint. So 48 months compared to 33 months. So improved the overall survival with a hazard ratio of 0.63. This is how that was also overall survival according to the volume. So that benefit was seen mainly into the high volume patients. The low volume, because maybe one of them is the sample size for that group was small, about 33%, and maybe it needs a longer follow-up. This is the overall progression-free survival, which was also improved by adding docetaxel to the androgen deprivation therapy. The second study was the GTAG, French, mainly with the other European center. Again, the same design, but the docetaxel was given as a 9 cycles compared to 6 into the CHAARTED, compared to the androgen deprivation therapy. It didn't show any benefit in the overall survival. And subgroup analysis also did not show any benefit of adding docetaxel to androgen deprivation. So the question, why CHAARTED and not GTAG? And one of the reasons was because of the high volume disease was mainly into the CHAARTED compared to the low number. The small size also into the GTAG. The longer follow-up it needs maybe into the CHAARTED trial. And also post-protocol given to other patients. So all those points were entertained at that time until we have another study they call it the STAMPEDE, and this is one of the I think in this essentially one of the best designed studies where they have a multi-arms, multi-stage ongoing studies, and the plan is over 20 years they will report maybe more than 10 arms with a different intervention. For example, the standard of care is considered androgen deprivation therapy compared to the standard of care plus zoledronic acid, compared to standard of care docetaxel, compared to docetaxel plus zoledronic acid. That just only maybe one of the design, but we'll see later on how did they add another arms. In this study, it showed also that adding docetaxel to androgen deprivation therapy showed overall survival benefit with the hazard ratio of 0.76. So this is just to summarize the three where the CHAARTED and STAMPEDE showed the benefit. GTAG was not statistically significant. So a meta-analysis combined all the three studies, CHAARTED, GTAG, and STAMPEDE, showed that the overall survival benefit favoring the docetaxel arm with the hazard ratio of 0.77. The same for the failure-free survival. So that was the standard of care, at least for the last 2 years, is given the docetaxel for those patients who fit to get the docetaxel for 6 cycles to improve the overall survival benefit. In 2017, as expected, the abiraterone was also tested into the hormone sensitive through 2, again, landmark studies. One of them, LATITUDE, they call it. The other one is the STAMPEDE, if you remember the multi-arm, multi-stage study. So abiraterone, as I said, is an inhibitor for the 17-hydroxylase enzyme, which prevents the synthesis of the androgen. So they included all the de novo patients with the hormone-sensitive prostate cancer at presentation. The high volume definition in this group was defined according to the Gleason score more than 8 or a presence of more than 3 lesions of a bony scan. So this is again aggressive presentations compared to the chemotherapy. The androgen deprivation arm was given as the standard. Abiraterone was given in the usual dose, which is 1 gram daily, plus the prednisone. Prednisone, we give it as a part of that protocol because when you block that enzyme of 17-hydroxylase, there is a mineralocortical activities according to this ACTH. So that prednisone will prevent the complications, the hypertension and hypokalemia. So the primary endpoint was overall survival, and then a radiographic progression-free survival plus other endpoints. So if you see the androgen, if you see the arm with the abiraterone, most of them, they have this aggressive disease with a Gleason score more than 8, more than 3 bony lesion, and it showed there is about 38% reduction in the risk of the death, which is overall survival benefit, by adding the abiraterone to androgen deprivation therapy. So if you remember that adding also the docetaxel improved the overall survival, abiraterone did the same thing. And this was seen also among all the subgroup analysis, even those who had a visceral metastasis or poor performance status. It showed also 53% risk reduction in the radiographic progression or death. And also it showed into the other secondary endpoints, which is time to PSA progression, time to pain, next symptomatic. So name it, all these with the significant p-value, just adding abiraterone to the control arm. 70% also risk reduction into the PSA progression. As I said, into the pain progression, about 30%. Into the time to the subsequent therapy was reduced by 58%. And those also patients who progressed into the abiraterone, they received another treatment that will be called at this point as a castration resistance. So they are expected to receive docetaxel, enzalutamide, or cabazitaxel, or radium-223, which is considered one of the options for the castration-resistant prostate cancer. The adverse event was not something outside the expected side effects you've seen with the abiraterone into the other trials: hypertension, hypokalemias, mild increase into the ALT and AST, but it was very well tolerated treatment. So hypertension didn't require any treatment. Discontinuation, hypokalemia, 2 patients discontinued treatment due to hypokalemias, and the cardiovascular, 2 patients in each arm. So that was the first study, which is the LATITUDE. At the same time, in ASCO 2017, STAMPEDE study. If you remember the STAMPEDE trial where they tested the docetaxel. So this is, as I said, ongoing study. So they recruited another arm, started in 2011 to 2014, where they tested the abiraterone plus androgen deprivation therapy, and they compared it to the standard arm, which is the standard of care plus androgen deprivation therapy. Primary endpoint was overall survival, and the other endpoints is progression and toxicity, quality of life, and cost effectiveness. So the number of the patients in this arm was higher than into the LATITUDE. So around 950 patients in each arm. Patient characteristics, the only difference, maybe one of the differences that you've seen into the LATITUDE, all the patients at the time of the presentation, they had a hormone sensitive metastatic. Into the STAMPEDE, about 52 metastatic, but they included what they call them M0, which is localized or advanced prostate cancer patients. It showed more or less the same as you've seen with the LATITUDE trial, where the reduction about 37 into risk of death, so improvement into the overall survival. Also 71% improvement into the time to failure, as well as skeletal related outcome was reduced into the M0 by about 55% by adding abiraterone to that. Those patients who progressed in abiraterone received as the other standard. So a table to compare the LATITUDE with the STAMPEDE. As I said, most of the patients here, 100% metastatic, 52 metastatic, and 100 patients also M0. Those are the included the M0 and M1. So the hazard ratio more or less the same, so 0.62 and 0.61 into the 2 trials. This is the overall survival. So a meta-analysis just conducted even fast, while that presented just only in ASCO, but it showed also that about 14% absolute improvement into the survival at 3 years by adding abiraterone to androgen deprivation into the hormone-sensitive metastatic prostate cancer. Those are the side effects we just mentioned. So another presentation in ESMO was comparing, if you remember the STAMPEDE, we have the abiraterone plus androgen deprivation arm, and they compared it to the docetaxel plus androgen deprivation arm into the same. It was not, they have the 2 arms, and it showed that there is a strong evidence favoring an abiraterone and reduction of the progression-free survival and failure-free survival. But an overall survival either docetaxel or abiraterone where it's made. So this is a kind of a direct comparison between two arms into the same study, which is the STAMPEDE. This is another study ongoing, and this is by Karim Vazazi, where they going to test the standard of care. And the standard of care in this study will include docetaxel compared to the abiraterone plus radiation, or to the docetaxel plus radiation, or to the docetaxel plus abiraterone acetate. So that will give us also more evidence on the first line into the hormone sensitive. So in conclusion, in a hormone naive or hormone sensitive prostate cancer, abiraterone and prednisolone improves the overall survival, failure-free survival, symptomatic skeletal events. It was a well-tolerated treatment. So abiraterone should be one part as a standard of care for men with a metastatic hormone-sensitive prostate cancer, plus the chemohormonal, including the docetaxel. I think with this, I'll just conclude my talk. Thank you.